this topic that I'm going to just review, hopefully briefly, because it's a complicated topic, but one that is has an impact on everyone, whether we have Parkinson's disease or not. And the theme here is the change in our cognitive capacity, our thinking, our intellectual processes. It's a constantly changing world, and our ability to learn changes. You know how rapidly kids learn, and how easy it is to learn a second, third, and fourth language before you're an adolescent. And then afterwards, how difficult it is. And then what happens as we get older is that certain aspects of thinking, of cognitive function, which is another way to say thinking, or intellectual function, it's all of those activities of the nervous system that are kind of intangible, but you can see the results of that activity. So memory, planning ahead, abstract thinking, mathematical ability, that kind of spatial orientation, visual spatial skills, all of those are intellectual functions that change with age. And the one that everyone notices when they get older is the short-term memory, just forgetting what you just did. And everyone has some of this. I mean, the beauty of the nervous system is that it can learn new things, but it also forgets on purpose. I mean, there's a whole reason that we forget. I always like to say, if we didn't forget, we'd no longer have any new births, because the pain of childbirth is so severe. If the mother remembered that, she would never want to have another child. And so you kind of forget the pain. Yeah, you know it conceptually, but yeah. So it's, and there's an active process of forgetting. We don't like it when we forget names, but this is very common. Or we forget to do things that we thought we had in our mind, and we end up reminding ourselves with all kinds of notes. And it's very clear that it's more than just memory that declines as we get older. And it varies tremendously amongst individuals. It turns out that if you were at a very young age, were very intellectually active and were really a studious person and continued to study most of your life, your cognitive decline will be a lot less, and maybe not even noticeable, than if you never learned to read or write, and never had that many intellectual challenges, and all you did were manual tasks. You might be very good at certain things, but as you get older, your capacity to do some of these intellectual functions, which you never really mastered, it's going to be really, really, really compromised. One of the interesting things about, and I'm going to get back to the real purpose here, is what about dementia in Parkinson's patients? How does it differ from just dementia as we get older? And rather than saying dementia, what we like to say is cognitive impairment, because dementia has a strict definition, which I'll get into. But cognitive impairment just refers to a diminishment of certain cognitive functions. And there are 4 domains of cognitive function that we kind of speak about. I'll get into those in a moment. And all you need to do is have one of the domains gradually decline, and you'll suffer from, quote, mild cognitive impairment. And everyone, as we get to be 60 years of age, has some elements of cognitive impairment. There's some statistics and epidemiological studies that look at this. For example, mild cognitive impairment can occur as a transitional state between normal aging and dementia. And basically, where's that number? I can't find the number. But in any case, roughly about 20% of Parkinson's disease patients have mild cognitive impairment. It's not talking about dementia, just to have some mild cognitive changes that you're all familiar with. It's a little bit more than what you might have if you didn't have Parkinson's disease. But in general, 20% of us with Parkinson's disease have cognitive impairment. Now, the cognitive profile of Parkinson's disease patients who develop frank dementia, where mild cognitive impairment is a concept that came from the Alzheimer's disease field. And there was a transition between normal intellect and the dementia of Alzheimer's disease. They call that transition mild cognitive impairment. And it turns out that mild cognitive impairment is also a transition into the dementia of Parkinson's disease. There's differences in the mild cognitive, in the profile, the cognitive profile of Parkinson's disease with frank dementia versus Alzheimer's disease dementia. I'm going to speak to you about that. Basically, contrasting and comparing the dementia of Alzheimer's disease with dementia that occurs in patients with Parkinson's disease. And in both situations, there's a transition called mild cognitive impairment. Now, the dementia of Parkinson's disease can be distinguished from dementia of Alzheimer's disease based on certain characteristics. And the best way is a set of questionnaires and interviews by neuropsychologists. But in general, problems with attention, executive function, and visual spatial functions predominate in dementia associated with Parkinson's. Spatial orientation. This is why people with Parkinson's disease dementia have problems driving. It isn't that they're slow or rigid, have bad reaction time, it's that orientation of their driving in space is bad. They begin to make right turns and run over the curb or hit a few mailboxes because of poor spatial judgment that happens. In Alzheimer's disease, the most dominant thing is orientation, disorientation to time, person, and place. They eventually can even not recognize people. Or of course, memory is a very important component that early on that declines. So for them, it's orientation in time and space and memory. Those are much more typical of Alzheimer's disease. In both, there's a decline in memory. In both, there can be a problem with orientation. But a person with Parkinson's disease dementia will not get lost in his own house. Someone with Alzheimer's disease may get lost in their own home, where they go into the closet thinking it's the bathroom, in a house they lived in for 40 years. That won't happen in Parkinson's disease dementia. That's an issue of orientation in place. The visual spatial orientation I spoke to you about in Parkinson's disease has to do with your body in space or your vehicle in the environment. There's a few things I want to get into about the diagnosis. There's a few interesting things. So we know that Parkinson's disease is predominantly a motor disorder, and that's what we've really focused on. But anyone with Parkinson's disease motor problems has a six-fold risk increase of developing dementia. I didn't realize it was that high. So a person that's 60 years old who doesn't have Parkinson's disease has a certain risk of dementia. It's small but definite. And a person with Parkinson's disease has 6 times that risk. So having Parkinson's disease increases the risk of developing cognitive decline. And you've got to remember this, the most common of all brain disorders, neurodegenerative brain disorders, is Alzheimer's disease. The next most common is Parkinson's disease. So since they're both common, it's not unusual to have Parkinson's disease and Alzheimer's disease, what looks like it. And that's why we've always thought anyone who has severe cognitive problems who also has Parkinson's disease probably has both illnesses. But we know they're very different. And we can distinguish the dementia of Alzheimer's disease from the dementia of Parkinson's disease by in many ways, in addition to the cognitive profile. MR imaging is for one, the pathology is very different. For example, the dementia of Parkinson's disease has a different underlying pathology. In other words, looking at the brain tissue, looking at the underlying forces, we see that Lewy bodies, the malformed Lewy body, proteins of Lewy bodies that accumulate in the brain are the basis of Parkinson's disease dementia, whereas amyloid plaques and neurofibrillary tangles are the basis of Alzheimer's disease. In certain cases that have been looked at, you can see both Alzheimer's pathology and Parkinson's disease pathology. And that would be an example of where a person had the two most common disorders. Unfortunately, they got both of them. But most of the cases of dementia with Parkinson's disease don't have Alzheimer's pathology. Their MR of the brain doesn't reveal the shrinkage of the hippocampus that you see in Alzheimer's disease. And the morphology of the brain looks different in Alzheimer's disease. PET scanning is different in Alzheimer's versus dementia and Parkinson's disease. Looking at metabolic activity, that's what I mean by PET scanning, which is a way to look at in vivo biochemistry of the brain, whereas MRI looks at structural differences in brain. And there are differences between Alzheimer's disease and Parkinson's disease dementia. So how do we make that clinical diagnosis? And in fact, the Movement Disorder Society was really concerned that we're not making the diagnosis of dementia associated with Parkinson's disease appropriately. We've tended to think, oh, it's just Alzheimer's disease. That, like James Parkinson and many other people in the past, that Parkinson's disease is a motor disorder. It does affect mood and sleep, but it doesn't affect thinking. The intellect is left unchanged, it was thought. But we know it's not. The intellect changes. So the diagnostic criteria, they proposed 4 clusters of features. Number 1, the core feature is that you have to, of course, have a diagnosis of PD first, before you can say it's PD with dementia. Because there are many, many people with dementia who don't have Parkinson's disease. So first thing is, does a person meet the criteria for the diagnosis of Parkinson's disease? And that may not be that simple early on, especially early on in the illness. In fact, that brings up, I should bring it in here because towards the end I was going to bring up dementia with Lewy bodies, which is different than Parkinson's disease dementia. It sounds, they both have Lewy body pathology, but the Lewy body dementia, or dementia with Lewy bodies, presents with cognitive changes before the motor problems, right? Before the Parkinson's disease is diagnosed. Or within a year of having the dementing symptoms, which can include hallucinations, confusion, and psychosis. And this is without any medication, by the way. This is a 60-year-old person who starts getting confused, disoriented, sees people in the house that aren't there, and within a year, you notice they have tremor and rigidity. Well, that person doesn't have Parkinson's disease dementia. That person has dementia with Lewy bodies, where the dementia began before the development of the motor symptoms, or within a year. Whereas in Parkinson's disease, the diagnosis of the movement disorder occurs many years before the development of the dementia. In fact, on the average, the dementia that I'm speaking about here, called Parkinson's disease dementia, which differs from dementia with Lewy bodies in a number of ways, tends to develop many years, 10 years after the onset of the motor features. And that's the kind of dementia that we see most often. People who have advanced Parkinson's disease. Generally, the risk factors for developing dementia in Alzheimer's disease has to do with age and the nature of the Parkinson's disease. So someone who's older, in their late 70s and 80s, who's had Parkinson's disease since they're 60, and who has, what are a few other things? I forget some of the other things. See, I'm getting there too. It's actually a complicated topic because there are 3 different dementing conditions. I didn't talk about my dementing condition, but in essence, the older you are, the form of the Parkinson's disease will increase the risk. So if you have rigid akinetic predominant without tremor, you're more likely to develop a dementia than if you have tremor predominant. So tremor predominant tends to spare the intellect, even though it's troublesome to people because many of the meds we use for Parkinson's disease don't alleviate the tremor very much, and so they're upset. But it's better in the long run not to have to be not rigid akinetic throughout. Having the tremor seems to distinguish between those who will get the dementia or not. In addition to having the core feature of Parkinson's disease, you have to have developed the Parkinson's disease at least a year before the dementia, many years before, typically. You have to have a global cognitive decline, and that's determined by the mini mental score, which I'm going to go over. It's a very crude way of of looking at 5 domains of intellect. And if you score below 25 on this, then you have mild cognitive impairment or dementia. And so if you have Parkinson's disease for many years and then you score poorly on this mini-mental test, that's one of the factors that will support the diagnosis of dementia with Parkinson's disease. And to really call it dementia, the difference between mild cognitive impairment, which can involve only 1 or 2 domains of thinking, dementia is when 2 or more domains are involved and they interfere with your ability to function in daily life. That's what dementia is. There has to be an impact of those cognitive changes on your ability to function. So your ability to pay the bills or to take care of certain things that require balancing the checkbook, for example, or just everyday activities that require attention. This is one of the things that really goes in Alzheimer's disease, or that require executive functions where you have to follow through on a set of activities where you have to do them in sequence. Well, that becomes highly compromised in the dementia of Parkinson's disease, and so people have an impact on their ability to live independently. In fact, Parkinson's disease plus the dementia full-blown is one of the major reasons people need a lot more nursing care and end up in nursing homes. That and falls. So Parkinson's disease, profound dementia with inability to do anything on their own, is a big burden on the caregiver, and often they need help. So that's the core features for Parkinson's dementia. You have to have Parkinson's disease, you have cognitive impairment, and several years later you develop cognitive impairment in at least several domains of thinking, and those cognitive impairments impact your ability to function independently. Independent of your motor deficit, your ability to think. It's really a dangerous thing if someone forgets to turn off the stove or turn off the water in the tub, or that kind of thing. So, those are the things that can happen with cognitive impairment. Now, how do we manage that? Well, before I talk about management, I'm going to talk about dementia with Lewy bodies. Now, many of you know, and when I give talks with slides, I have a picture of the Lewy body pathology. Lewy bodies were first described in 1913, and these are nothing but abnormal cellular deposits. And they're found in the neurons of the substantia nigra, but they're found in many other neurons. In fact, they were first described in the olfactory bulb, which is in the front of the brain, and in the brainstem. That's where they were first seen, and no one thought it would have any relationship to the actual movement disorder of Parkinson's disease. But a really amazing study that looked at the distribution of Lewy bodies in hundreds of brains of individuals that had in life Parkinson's disease led to the classification of stages of Lewy bodies disease. So in the very beginning, the Lewy bodies can be found in 8% of normal people, 60 years or more, in the olfactory bulb and in the brainstem. And it appears to not have any significance, maybe constipation, because in the vagus nerve, that's the main nerve that supplies the gut, and perhaps that may be one of the early prodrome of Parkinson's. So the Lewy bodies are just in the lower, in the medulla, and when those Lewy bodies are found in the midbrain, that's when the first symptoms of Parkinson's disease occur. So it appears to be a constantly changing distribution of Lewy bodies. And the more the Lewy bodies distribute, as the illness advances, the more the Lewy bodies have spread throughout the whole brainstem. And when the Lewy bodies are involving the cerebral cortex, where a lot of higher cognitive processing is occurring, that's when dementia develops. Now, in the case of Lewy body dementia, amazingly fast spread of the Lewy bodies. So people with Lewy body dementia, if you look at their brain, they may have very little of problems with their movements. They have, slowness and rigidity. But the striking thing is their dementia, where they're very confused, disoriented, hallucinate, have psychosis. And you look at the brains and you see Lewy bodies throughout the cerebral cortices. So it's like Lewy body disease gone rampant. That's what dementia with Lewy bodies is. And diagnosed by the appearance of the cognitive issues before the movement disorder, or at least a year before the movement disorder becomes apparent. And typically there's a lot of hallucinations. That's one of the warnings. Now, hallucinations in Parkinson's disease are common. Up to 26–30% of people with Parkinson's disease without dementia will develop hallucinations, but that's related to the use of the anti-Parkinson drugs. So people who do have developed hallucinations, with 25% of them with Parkinson's disease, we can adjust the medications downwards and maybe add something to prevent hallucinations, and they do better. In the case of dementia with Lewy bodies, you have to treat the hallucinations right away, and we use drugs that don't block dopamine receptors. You who have followed me over the years and talking about this know that the drugs to treat psychosis are contraindicated in Parkinson's disease because they're anti-dopamine drugs. That's in fact how dopamine relevance was discovered, because the major tranquilizers in the 1950s were shown to produce Parkinsonism as a side effect. And it was shown to be due to the blockage of dopamine receptors. So we can't treat psychosis and hallucinations with the standard antipsychotic drugs like Thorazine, Haldol. So there's a novel type of tranquilizer, antipsychotic drug. First was Clozaril, but that has too many adverse effects. The next, the one I use most often, is quetiapine or Seroquel. That will block the hallucinations, improves normal sleep, and correct a sleep disorder that is another component that we've discussed in this Ask the Doctor session. So that's how we treat it. And if you were to start treating the movement disorders without protecting against the capacity of the drugs to worsen the psychosis, then you're in trouble. So you have to start off with an anti-hallucination medication like Seroquel. It's also an antipsychotic and also improves their sleep. But then you can introduce the levodopa and gradually increase it till their motor function is better. It's a very big challenge because as soon as you go above a certain threshold of levodopa, carbidopa, or dopamine agonist, you can worsen the dementia. We did a study years ago of 250 consecutive patients that came to the University of Miami and Ohio State. We did it in collaboration with Dr. Paulson at Ohio State. And we did a study of hallucinations and psychosis. In every patient that came in, we had a hallucination and psychosis questionnaire. And we were interested in what the risk factors for the hallucinations was in the broad Parkinson's disease population. And we found that in our study, it was 26% of the people that we interviewed and administered this questionnaire to, they had visual hallucinations in the last week. I was wanting to know if they were recently having hallucinations, if they ever had them, and if they were having them still. And what was interesting, we also questioned about delusions, other aspects of thinking. But the thing that we found most intriguing was of the non-hallucinating patients compared to the hallucinating patients, the total amount of levodopa and dopamine agonists was not different. So it wasn't that the drug was causing the hallucinations per se, because the total amount of drug given to those patients who had hallucinations was the same as those that didn't have. So we looked at other risk factors for the hallucinations. And it turned out that those individuals that had a significant sleep disorder, that had been recorded that they had a sleep disorder, most typically, the most common one is called REM behavior sleep disorder, where people act out their dreams, they have fragmented sleep, they have abnormal sleep architecture. Those people were the ones that had the greater risk for hallucinations. So having a sleep disorder, and also the age, the patients who hallucinated tended to be much older than the ones that didn't hallucinate. And finally, the individuals who were being treated for depression, that had depression, and that's a very common, were slightly greater in the hallucinators than the non-hallucinators. But I didn't make that much I didn't see how that really had an impact, because the drugs themselves for treating depression don't cause hallucinations by themselves. There are drugs that we give to Parkinson's disease patients and even to healthy 60-year-olds, there are certain drugs you shouldn't take because they can cause delirium and hallucinations, and that is the artane cogentin type drugs, the belladonna alkaloids. They block acetylcholine, very critical neurotransmitter in the striatum. If you block that, you develop a dementia and hallucinations. So anyone who's greater than 60, we don't ever, if they have tremor predominant, Parkinson's disease, Cinemet's not working, you have to be really careful about using artane, because it'll precipitate hallucinations and psychosis. So now we've discussed the difference between Alzheimer's disease and Parkinson's disease. Those are not difficult to distinguish with our nowadays. 10, 15 years ago, it was a little bit harder. Then there's a distinction between Parkinson's disease dementia and dementia with Lewy bodies. And that is, if you get a good history, should be easy to distinguish, because in dementia with Lewy bodies, you start off with the dementing process and hallucinations early on. They may not have hallucinations, but they have, behavioral disturbances, for example, and cognitive decline before they develop the movement disorder. And the rate of progression of the two is completely different. So people with dementia with Lewy bodies have a very rapid decline. And I think of all the patients that we work with, they're the most difficult. They have Parkinson's disease, but that's the least of their problems. It's the cognitive issues. So how do we treat the cognitive issues in dementia with Lewy bodies, Parkinson's disease dementia, and Alzheimer's dementia? Remarkably, it's very similar for Alzheimer's disease and Parkinson's dementia, because in both cases, there seems to be, acetylcholine seems to be very important. Just as I mentioned that blocking acetylcholine receptors will produce hallucinations and delirium and confusion, activating those acetylcholine receptors by giving a drug like that inhibits the breakdown of acetylcholine. In other words, to promote the levels of acetylcholine to a higher level and therefore stimulate acetylcholine receptors in several parts of the brain, those tend to be enhanced cognitive function. So the first class of drugs to do that were the one that many of you know is Aricept. It's used for Alzheimer's disease. We'll use it in Parkinson's disease dementia as well. But the only one that was proven to work in Parkinson's disease dementia, at least in one double-blind placebo-controlled study, was rivastigmine, which is a cousin of Aricept. It works by the same mechanism, but the nice thing about rivastigmine, you can deliver it as a patch. Exelon is the brand name. And that has some, even though it's been proven to be effective by double-blind clinical controlled studies, the effect is very mild, but it's worth trying in individuals who complain they're having memory problems in the context of Parkinson's disease. And that's it. There's really no special medications to improve cognition other than that. The latest one is called Nomenda, which is a cousin of amantadine. And I say cousin, it's structurally related. It comes from the same family. And amantadine, many of you know, is a drug that we use for mild Parkinsonism. We add it to individuals who are developing levodopa-induced involuntary movements, and it can help that. But amantadine itself, in some people who have mild cognitive impairment, can precipitate hallucinations. So you have to be careful. If someone is starting to develop confusion and hallucinations, one of the first drugs you can take away is amantadine, or lower the dose. The other drugs to avoid, I already told you, are anticholinergic drugs. But the cousin of amantadine, called memantadine, Nomenda, was originally being developed as an alternative to amantadine. But it was found to have some interesting effects in cognition to improve memory and other aspects of cognition. And that was approved for Alzheimer's disease dementia. So for Alzheimer's, there are two classes of drugs that are being used for the dementia that are available, FDA approved. One is, I already told you, Aricept and rivastigmine, and the other is Nomenda. Now, we're free to prescribe any of these for Parkinson's disease. I tend to prescribe Nomenda because it's well tolerated, and also you can see, I'm talking about dementia and Parkinson's disease, that Nomenda is useful. What else? I think that's all we need to speak about. I think there's a big need to develop better approaches to dementia, better approaches to prevent dementia in normal aging. Because as we age normally, we lose intellectual capacity. There are several ways to prevent that in aging and in Parkinson's disease. So I talked about medicines that we use, but if you really want to do more to improve your cognitive function, and by the way, to improve motor function, is aerobic exercise. Simple and straightforward as that. Aerobic exercise has some amazing effects on these naturally produced fertilizers in the brain called neurotrophic factors. Neurotrophic factors are responsible for maintaining the health of brain cells. And when there's a decreased production of neurotrophic factors, brain cells start dying back. In fact, that may be the real basis of Parkinson's disease. There's interference with the growth factors. There are two key ones, GDNF and BDNF. If we can increase production of those two growth factors, the dopamine neurons will re-sprout. It's almost like you let a plant go unattended for a week and it's dying, it's dried up. All you have to do is put a little water on it. You see how quickly it comes back. Well, that's what the growth factors will do to neurons. And there's evidence that it does that in monkey models of Parkinson's disease. And one of the ways that it works, the aerobic exercise, by increasing blood flow to the brain. And by the way, the aerobic exercise can't be done just once a week. You have to do it at least 3 times a week. You got to get your heart rate up. You got to get it up to 80% of max for your age. And when that happens, the increased blood flow stimulates production of these two growth factors, which in turn stimulate two things: the sprouting and maintenance of dopamine neurons and other neurons, and increases the production of new brain cells in the hippocampus, the key structure for forming short-term memories. So one of the best ways to improve your memory is to take very vigorous walks, cycling, or elliptical exercises. Now, it's easy to say, but harder to do if you have Parkinson's disease. Number one of the things that happens in Parkinson's disease is decrease in motivation. There's less drive, less interest in doing things. It's part of the depression. There's apathy. So how are you going to get someone to drive themselves to exercise? So you need the caregiver and the support to encourage that exercise. And once they get into it, it becomes a habit, and then they start seeing the benefits, and they don't ever give it up. So that's what I recommend. The medications I always bring up second. I bring up the alternative approach, which is exercise. The exercise is so important that they're doing multi-center studies in Alzheimer's patients of a very precise set of exercises in which they're monitoring all of these physiological parameters like heart rate, oxygen saturation, etc. And what they did was take a physical therapy unit that had experience with this, and they set up every center doing the study with the exact same apparatus, the same protocol. So that study's ongoing, and the idea is, the main objective is, what is the best kind of exercise? How often should an Alzheimer's patient undertake this exercise to keep their cognitive processes from decaying further and maybe actually enhancing some cognitive processes? Similar studies are not being done for Parkinson's disease dementia, but I think they will soon follow. In fact, what we learned from the Alzheimer's study we'll be able to apply to the dementia Parkinson's disease. Even though both of these conditions differ pathologically, the end result has a certain similarity, though remember what I mentioned, that the domains of intellect that are involved in Parkinson's dementia is different to really a significant extent from the domains of cognitive function involved in Alzheimer's. But in both, there can be memory problems, executive problems. And those can be improved by exercise, and perhaps the memory problems with these drugs. So I wanted to show you what a mini mental exam is like. It's a very crude screening instrument that I don't do very often. Usually if I suspect a dementia, and I suspected dementia with Lewy bodies, but I'm not sure if it's Alzheimer's, because it wasn't sure when the motor features began and when the Alzheimer's. This is very often, people are not really clear as to when their motor manifestations appeared because it's very insidious. That tremor that began about 5 years ago, they didn't pay much attention to it, and then you see them, and a year ago they developed, started having hallucinations. Well, but they don't remember having any involuntary movements or any motor control, so any motor problems. So it's often difficult by history to determine whether there's a dementia with Lewy body versus Parkinson's disease dementia. But the screen that we do, it would be, before I would send someone for formal neuropsych testing, this could be done. Formal neuropsych testing is the most thorough way to distinguish between the three kinds of dementia. And it takes 3 or 4 hours, and it's very frustrating, so it's hard to do for many patients. It's a good way to distinguish Parkinson's dementia from Alzheimer's disease, from dementia of Parkinson's disease, from the dementia associated with vascular disease, which is a very common form of dementia. And by the way, many of you heard me talk about vascular Parkinsonism. Well, that's a disorder that is not due to Lewy body deposition. It's different than Parkinson's disease because it involves the lower body first, and they can develop a dementia, but that comes on later, and it's a global kind of dementia. But that has to be distinguished from the dementia of Alzheimer's disease. So formal neuropsych testing is done to help with that. But screening for just cognitive impairment or mild cognitive impairment involves the mini mental state examination or the Palsy test. And if you score 25 out of 30 or less, you have cognitive impairment. And the lower the score, the worse it is. So the first sets of questions have to do with orientation, and that's where Alzheimer's patients do terribly, but Parkinson's disease with dementia do well. The orientation is, what year is it? What season is it? What date? What's the day? What's the month? Where are we now? What state? What county? What hospital? What floor? So all of those things have points. In Alzheimer's disease, they fail in those. Those are orientation questions. Then the other thing is attention. Now, attention suffers in both Alzheimer's and Parkinson's disease, but attention, how do you measure attention? Well, one of the ways, and its ability to, for example, can you count backwards from 7? So it sounds like a series, like a math thing, but it makes you pay attention. So you could, or spell world backwards. Spell it forward, W-O-R-L-D. Then I'll ask the patient, spell world backwards. And you have to really pay attention and visualize that and spell it D-L-R-O-W. Well, you'd be amazed how difficult it is for people with Parkinson's disease or mild cognitive impairment, not Parkinson's disease. Parkinson's disease patient can usually do that, but if they can't, then they have very likely a domain of attention is affected. So for memory, we'll usually, and naming, I'll give them 3 objects to name. What's this? And you see it's a watch, and this, it's a pen, and this, eyeglasses. And then 5 minutes later, I come back after I've asked a few other questions. So what were those 3 things I asked you to remember? So that would be a short-term memory challenge. And then for the speed and dysarthria and ability, the language capacity, I'll have you repeat a few things after me, just to make sure there's no aphasia that would be more likely due to vascular disorders, or dysarthria that might be a slurring of speech. So repeat this phrase, no ifs, ands, or buts. And then sequence of commands that I want the patient to follow on. So I'll give the patient, by the way, our psychologist usually does this. I don't do this test, but I could. I'm going to give you this paper and give you a set of things to do with it. So before I give it to you, I'm going to give you the paper. I want you to fold it in 4 and put it on the ground. So you see I gave 3 commands. And if they have a cognitive impairment in executive function, following through a sequence of commands, or they'll have a problem with that. They may fold it in half and then they don't remember what the next thing to do is. So that would be a... And then I give them a picture to copy, and that has to do with visual spatial orientation. So when you add up all the score on this kind of very simple mini mental test, you can determine if there's a cognitive impairment and how severe it is. It's a good screen for mild cognitive impairment. If there is mild cognitive impairment, you might want to start something to, I would say, better start your exercise program, because people with mild cognitive impairment have a greater risk of developing full-blown dementia and Parkinson's disease. So I think I'm going to end there, and I'll take some questions.
What is vascular PD?
Well, it's called Vascular Parkinsonism, and about 8% of cases of Parkinson's syndrome are attributable to problems of blood flow in the terminal vessels of the brain. And remember that all the arteries that supply the brain, provide nutrition and oxygen, they come up through 4 trunks, the 2 carotids, the 2 vertebrae. They're big. And they branch and they branch and they branch. When you have occlusion of a medium-sized vessel, you'll have a stroke. You'll notice it because the tissue that's supplied by that branch is going to die, and people will be hemi-paralyzed, hemiplegic, or dysphasic, or have visual loss on one field. That would be a classical stroke, and that's nothing to do with Parkinson's disease. Let me finish. I'm leading up to explain what your answer, what you wanted to. When the blood vessels that are occluded are the fine terminal capillaries that will end terminal branches, it results in tiny signals in the MRI of the brain, but more importantly, it can produce lower body Parkinsonism. So a gait, it's hard to move the gait, and the arms loose like this. So the people who come to the clinic and you ask about how the illness began, and say, well, I began to fall, I began having problems initiating my gait. Then you see they have a history of high blood pressure, diabetes, and they're older. That would be the setting for vascular Parkinsonism. Now, vascular Parkinsonism isn't due to Lewy body disease, isn't due to the loss of dopamine neurons, but it has to do with the loss of projection neurons from the leg region of the brain, which is undercut by the vascular occlusions that supply the deep gray structures of the brain. And those leg regions are undercut first, so you have what looks like Parkinson's disease of the lower body. That's called lower body Parkinsonism. Eventually, as the disease progresses, the upper body gets involved. So I'll see people that have loose arm swing, but they have really slow hand movements. That's lower body Parkinsonism, and doesn't get better with levodopa, carbidopa. So, yeah.
We received an email today from a friend, and she said she's been diagnosed with PSP.
Progressive supranuclear palsy.
What's the middle word?
Progressive supranuclear. And that's a neurological term that refers to above the cranial nerve nucleus. Every cranial nerve, say the cranial nerve called the 7th cranial nerve, innervates all the muscles of the face, comes out here. So upper motor neuron means the facial homunculus from above that's innervating the lower motor neuron. So it's called supranuclear. So what happens in progressive supranuclear palsy looks just like Parkinson's disease. It starts with slowness, rigidity, often not tremor. It can respond to dopamine replacement for a while, but not as well. They tend to have more rigidity in the midline than in the arms, called axial rigidity. And the striking feature is the supranuclear palsy, and supranuclear palsy of the eye movements. So those motor neurons that innervate the ocular motor nerves, which is the lower motor neuron, to control movements, they're disconnected. And so people cannot voluntarily gaze up or down, and eventually they can't gaze. They have to go like this, and they have to go like that, or like that. So that additional feature makes it a Parkinson plus. It has 2 other names. Progressive supranuclear palsy, describing the problem of visual control, of eye movement control. And this third name was the original name of this syndrome, which is a Parkinson plus syndrome. There are many Parkinson plus. Parkinson plus means you have Parkinsonism, slowness, rigidity, tremor, plus some other neurological problem. In PSP, you have problems with control of voluntary eye movements. The interesting thing about PSP and Parkinson's disease, they both may respond to Sinemet, but in PSP, the pathology is very different. They don't have Lewy bodies, like in all the Parkinson's disease, and Parkinson's disease, dementia, and dementia with Lewy bodies. This one, PSP, has a pathology that looks like the post-encephalitic Parkinson pathology. So individuals who develop Parkinson's disease after an encephalitis was a generalized brain inflammation. Many of those people developed Parkinson's disease after this big epidemic of this, quote, Spanish flu, which is probably a swine flu. We're not sure that happened from 1916 to 1922. Millions of people around the world died from this encephalitis. If those survivors of the encephalitis developed Parkinson's disease. And the brains of those people, it was a little different. They had neurofibrillary tangles in the brainstem. And PSP has a similar pathology, but only in the brainstem, whereas in post-encephalitic Parkinsonism, the neurofibrillary tangles were more widespread, but mostly in the brainstem. One more question. Yeah.
If Parkinson's disease without tremor leads to increased likelihood of dementia,
Yes.
is the physiological cause known so that we can develop a treatment that would reduce the dementia?
No, it's just, no. We don't really understand why the tremor-dominant Parkinson's disease tends to have less risk of dementia. They can still develop dementia, so we don't understand that. But and it's not understood why dopamine replacement may not alleviate the tremor in many of the patients, whereas anticholinergic drugs would alleviate the tremor. But we have to be careful with using those drugs. And it's a simple kind of, initially it was oversimplified, that with Parkinson's disease you have less activity of the nigrostriatal dopamine. So you're slow and you're rigid and you may have tremor plus or minus. 1/3 of patients with Parkinson's disease never develop tremor. So you keep that in mind. You still have Parkinson's disease without tremor. So as you lose dopamine, the levels of acetylcholine in that striatum where the dopamine terminals reside goes up. So there's low dopamine and high acetylcholine. And that's associated with tremor, the higher the acetylcholine, and that's why probably they don't develop the dementia. Remember, the drugs that increase acetylcholine are the ones that we use to treat memory disorders in Alzheimer's and Parkinson's dementia. The drugs that block acetylcholine, which we would do in cases of severe tremor, because the dopamine's real low and they have really high acetylcholine, you block the acetylcholine at a low dose and you'll alleviate the tremor. Too much and they'll start getting dementia or hallucinations. So it has to do with the cholinergic system. And why that's the case, I don't know. But there's no, I think the solution for all of these dementing conditions is to get better understanding of the pathology and then have new targets. I know that one of the ways that we'll be able to stop the diseases, both Alzheimer's and dementia, Parkinson's disease, Lewy body Parkinson's disease, is by finding ways to clear those abnormal proteins or preventing them from accumulating. And that way you will end up preventing the dementia, the progression of the disease. You can halt it, maybe even reverse it. So that's where we're headed. So in the case of Alzheimer's, we're developing an immune approach to clear the amyloid. Unfortunately, it doesn't work for the neurofibrillary tangles, so it's not that great. However, there are, in Parkinson's disease, development of an immune or vaccination approach to the Lewy bodies. So these are things that are ongoing clinical studies and basic research studies. So I think that's the only way we'll really resolve this. But I think that why people with tremor-predominant Parkinson's disease are less likely to develop Parkinson's dementia, it has to do with the acetylcholine level, because that seems to be the key issue relating tremors and dementia or cognitive problems. Any drug that blocks acetylcholine can produce delirium and confusion. Some people will do it for fun. So many of the belladonna alkaloids are used by shamans in the Amazon as a way to kind of heal people. So they take belladonna, the angel trumpet is loaded with belladonna alkaloids, which are these anticholinergic drugs used by shamans to produce an altered state of consciousness. Many uninformed college students take the angel trumpets, make a tea, and end up in the emergency room because it can be very dangerous.
Yeah.
And that's excessive anticholinergic blockade. The use of agents that increase acetylcholine, we're using them for dementia. right? That's the first thing we do with Alzheimer's. We increase acetylcholine levels with cholinesterase inhibitors. These are drugs that block the enzyme that breaks down acetylcholine. So by taking these drugs, you have higher levels of acetylcholine, and it seems to improve cognition. An interesting thing about this is the beauty of pharmacology and toxicology, how they overlap. You know that the symbol for medicine is these snakes around the staff, and one man's poison is another person's medicine. So these cholinesterase inhibitors that we use therapeutically for dementia are also the drugs that are used in chemical warfare, the nerve gases, like sarin, or insecticides that we use to kill plants. They inhibit acetylcholine esterase and result in really high levels of acetylcholine in the brain that causes seizures and death. And some can be so toxic, and the sarin gas, for example. So insecticides are cholinesterase inhibitors. So in a sense, an insecticide in the right formulation, the right dose, is good for memory. It's mind-boggling, isn't it? It's sometimes too much information is scary. But I have another really fascinating, and you've all heard of myasthenia gravis, what Onassis had. He died. It's a neuromuscular disorder where the nerve muscle synapse has problems with the acetylcholine receptor. So it doesn't work. There are antibodies. This is a disorder where antibodies develop against the acetylcholine receptors outside the brain, in the muscles. So people become weak and they tire easily. Their eyes droop. And there's a certain overlap of the tiredness you get with Parkinson's disease. But myasthenia gravis is an autoimmune disorder. And the miraculous treatment was these pesticides, because there's not enough acetylcholine, right? Or there may be or may not be, it depends on the nature of the myasthenia, but by increasing the levels of acetylcholine at the neuromuscular junction, we give mestinon, which is a cholinesterase inhibitor. And cholinesterase inhibitors, I told you, are pesticides, as well as pro-cognition agents, and the major treatment for myasthenia gravis. Now, in myasthenia gravis episodes, sometimes the mestinon doesn't work anymore, and you have to do an immune treatment. You remove all the immunoglobulins from the blood. It's called plasmapheresis. Many people in the past have wondered if Parkinson's disease is an autoimmune disorder, but all of these ways of cleaning out, there's never been any autoantibodies discovered against the nigral striatal system. So I think that's it. I have to get ready for the clinic. Thank you.